Thank you very much, John, and good morning, ladies and gentlemen. It's a genuine pleasure to be with you and to reflect on the growth and evolution of our Academy. What I propose to do in the next while is to reflect on 5 areas. First, to remind you as to what the Academy is and how and why it developed. Give you some insight as to its evolution since its inception and its relationship to the Council of the Canadian Academies and other bodies. And then finally, reflect on some of the unmet needs that you and I would perceive might be appropriate as we look to the future, and some of the imperatives that I think we should reflect on over the next decade. The document which is available when you entered the meeting is depicted here, and I want to acknowledge John Cairns' outstanding presidency and leadership in putting this together. It was my privilege to help, and I think I'll draw from it in the first part of my remarks, but I really do commend it to the new fellows and even some of those a little longer in the tooth as it reflects on where we are and what we've done. We were created in 2005, and the expectation was to provide advice on and assessments of key issues that were relevant to the health of our fellow Canadians. One of 3 founding members, academies associated with the Council, and of course, a collaboration across the full spectrum of health disciplines, an advisory board that we created of 13 members, and of course, not-for-profit. The uniqueness relates, I think, to its multidisciplinary culture, all the disciplines under one umbrella. Remarkably, when one looks around and thinks globally, this had not existed in our country, yet it was flourishing. For example, in the United States, the Institute of Medicine, now the National Academy of Medicine, the UK, and internationally. We, of course, are not an advocacy group, and our task is to work towards enhancing the best interests of all Canadians as it relates to health, and we're independent, non-vested, and unbiased, so we occupy the neutral space or neutral ground. This colorful collage represents the multicultural nature of our Academy. And just briefly to step you through the mission statement, credible, expert, independent assessor of S&T issues relevant to health. We, of course, as the title suggests, want to recognize the outstanding leaders in Canada. We did that last night, but today we want to get down to business. Support timely, informed and strategic advice on urgent health issues and facilitate the development of sound and informed public policy on many of these issues. We, of course, are committed to enhancing the understanding of S&T issues, and I'll come back to that, affecting the public and transmitting the results of our assessments, providing opportunities for dissemination and public discussion. There are many voices, and we sought to provide a single authoritative voice as it relates to health science in the country. Originally, the idea was that we would monitor, and I still think this is a worthwhile objective, but I've shaded it because it's not yet in full flower. I think there's an opportunity to provide an early warning system relative to global health issues that we discussed something of last evening, and what our state of readiness is as it relates to potential future SARS and other threats to Canadian health. And of course, our expectation is that we would represent Canada internationally and liaise with other international academies. We're delighted that Victor Zhao is with us this morning as it relates to the National Institute of National Academy of Medicine in the United States. It is considered to be one of the highest honors, and I would add my congratulations to the new fellows who were inducted last evening. But importantly, it carries with it, the Academy Fellowship, a covenant to serve. And that word covenant was used and embedded advisedly as it relates to giving back to a social contract, if you will, as it relates to the privileges that many of us have had by being educated working in this country. This is a snapshot of where we began, and in pre-2000, I was part of the Canadian Institute of Academic Medicine. This was a group of roughly 100, plateaued at that membership, that was transformed into the Canadian Academy of Health Sciences. And you can see that progressively over the years that has grown with newly elected fellows, and now nearly 600 strong. Importantly, we have an increased representation of women, as that has grown, as is surely appropriate and desirable. The membership, as it relates to the health disciplines, is depicted here, and not surprisingly, a large component is medicine, but an important component of nursing, pharmacy, rehabilitation medicine, dentistry, veterinary medicine, and public health, and other elements associated with health science. And our breakdown, again, across every part of the country is represented in the Academy. So I think we are truly a national representative organization. What is the equity and the most important resource of the Academy? And of course, it's the fellows. It's their intellect, their wisdom. I would remind you that some of us think the relationship between knowledge and wisdom is the same as the relationship between maple sap and maple syrup. It's about 32 to 1, but we definitely want to extract your wisdom, and of course your experience and your sphere of influence. And we want you to be advocates and ambassadors for the mission of the Academy, as opposed to the individual cause or discipline from which your excellence and leadership has evolved. And we hope you share our passion, our impatience for change, and our readiness to contribute around issues that we think can enhance the future of Canadian healthcare. As Janet Bax pointed out yesterday, the Council was formed in these early days, and there are 3 member academies: the Royal Society, and we welcome the Royal Society's president, who you'll hear from presently, the Canadian Academy of Engineering, and the Canadian Academy of Health Sciences, which had its origins and important contributions from the Canadian Institute of Academic Medicine. If our equity is our fellows, our product, of course, is primarily our assessments. And I would remind you that the National Science Working Group, as the academies evolved, defined assessments as involving understanding of what we know about sciences underlying an issue, and more importantly, what we do not know, defining what questions remain unanswered. It establishes, if you will, a holistic view of complex issues and clarifies areas of concurrence, divergence, and uncertainty where they exist, and examines the validity of the sciences informing the issues. The criteria for selection, our president pointed out yesterday, and I would simply remind you of them, but also highlight that when we decided that we would be conducting independent assessments at the time of our genesis, we felt that it would be important to at least provide an a la carte menu, if you will, of strategic options on which decisions could be made based on the assessment of the evidence. So this is not a prescriptive set of recommendations, but we think hits the right seam in relationship to exploring actionable options. Let me take a few moments to reflect on some of the products, and I think at this juncture, certainly the return on investment in health research is clearly, I think, stands as one that has stood the test of time, was one of our earliest full assessments. It was our earliest full assessment, and certainly I think over the ensuing years has been the subject of a fair amount of discussion, and indeed has been incorporated in a variety of organizations, was an important part of the CIHR strategic planning exercise, was involved in the federal government's S&T strategy, and continues to be involved in a variety of organizations, healthcare, as well as internationally. At this point, I just want to pay tribute to my good friend, Cy Frank, who we lost this year. He was an incredible leader, a visionary, and his contributions to the Academy and to this assessment are, I think, indelible and important. The ROI assessment had 5 domains, as depicted here, and 84 separate indicators, and it was, if you will, a template. It was an opportunity to use this template depending on what one wished to evaluate, and I think has stood the test of time and been incorporated and referenced in a variety of international ways, and indeed during Cy's lifetime was the subject of a graduate course that he taught in Catalonia and lectured in Sweden and elsewhere around the world. Subsequently, important work associated with chronic health care, Louise Naismith and Peggy Ballum, the important scope of practice document by Jeff Turnbull and Sabine Nelson, Peter Singer's work on the international global health issue, Paul Ellison on oral health care after James Lund, inspiration in getting this going. Our collaboration with the Royal Society on early childhood development, and a forum such as this one happened to be on end-of-life care, are part of the products of the Academy at this juncture. The forums John spoke about yesterday, and I won't revisit those except to say that there have been a number, I think, that have been interesting and important and deserve reflection and potentially future development. And yesterday, I think we really did grapple with and I think grasp the essence of the challenge in dementia, and one hopes that indeed a question that the Academy can address will emerge. Let me move to the final 2 issues that I want to discuss with you this morning, and spend some time thinking about unmet needs for our country and imperatives for our Academy. I will take as my text from Proverbs, "When there is no vision, the people perish." And I'll show you this road sign from Tofino on the West Coast, which indeed suggests that vision is indeed rather limited on some of these issues. This appeared in the National Geographic in January of this year, and provides some context for those of us interested in health science as to what we're up against. Victor, although I'm pointing at the United States, the scientific method doesn't come naturally, but if you think about it, neither does democracy. National Geographic says that 1/3 of Americans believe humans existed in their current form since the beginning of time. Less than 1/2 believe that they are responsible for global warming, and others believe that the moon landing was faked and that vaccines cause autism. So there is a certain point of view out there that science needs to contribute to as it relates to our future, and I suspect that the numbers are not all that different north of the border. Well, we can be upset by these issues, or we can use the wind that blows in our face to move forward and keep our balance. One of the revolutions presaged in 2004 that is with us now, of course, is the electronic information revolution as depicted here. And I want to spend a few moments reflecting on that. It's incredible ability to monitor, to gather information, and to make sense out of complex biologic systems by the acquisition of huge amounts of personalized data and sequential data over time that allows individuals to be serving as their own controls. The iPhone, of course, and its ability to self-monitor is here and is happening, whether we believe it or like it or not. And in fact, many of our patients are using these devices as we speak. This has been characterized by Bob Harrington as the wearable decade, from watches, patches, and tattoos, as you can see here. And this data that is accumulated is extraordinary in its richness, and allows for trend algorithms to emerge, whether one wants to characterize the progress of an athlete or a patient, and leads to indeed the potential for decanting the location of care and the type of care. And we heard some sniff of that promise as it was discussed in relationship to the dementia discussion yesterday. But this indeed is a revolution of which I think those of us interested in health science need to be part of, aware of, and utilize wisely and well. The challenge, of course, is what to do with the data. And as highlighted here in this cover of The Economist, and for those of you that are in a position, and most of you are, to mentor young people, you might want to refer them to this Harvard Business Review that the data scientist is likely the sexiest job of the 21st century, and managing this data is going to be increasingly important in terms of making sense out of what indeed already exists. Google has taught us many things, and Google is now very much involved in healthcare, but the National Research Council in 2011, in its discussion of precision medicine, took the lessons of Google as depicted here and basically carved this knowledge network, which characterizes the exposome, the signs and symptoms, the genome, the epigenome, the microbiome, other sources of patient data and individual data, takes this extraordinarily rich collage of information acquired from multiple sources and then pops it into this knowledge network. And if one thinks about this knowledge network, and on the one hand, biomedical research and how it informs the mechanisms associated with discovery and the molecular characterization on the one side, and takes the clinical medicine and the observational data from population health and registries and clinical discovery on the other, and then captures that in electronic health records, then one sees how rich this information commons can become, and how the intersections of these elements can lead to enhanced understanding, perhaps improved taxonomy, and that in turn informing the direction of future research and the enhancement of best practices as it relates to the care of our patients. Well, as Waldo reflects to his younger brother, years ago there was only one Santa Claus. Now, because of genetic engineering, there can be lots of them. Is this where we are, or is it time to reflect in relationship to this promise of genetic engineering? Well, David Naylor reflected on this article, which I believe is very worth reflecting on, by Horn et al., published in Lancet earlier this year. And I think, Mr. President, this actually characterizes what was in our minds over 10 years ago, but we didn't articulate as well as is done here. The 4P of medicine: predictive, preemptive, personalized, and participatory. So truly personalized medicine is not just the genetic and biologic profile, as was originally articulated, but in fact is tailored to the psychosocial modulators of the motivation to engage. Judith Hall will be happy to see that the transdisciplinary approach is emphasized here, as was the case in our very first assessment that she led in the Academy in those early days. And it emphasizes what I pointed out and would re-emphasize, that we have a social contract, those of us in the Academy, between the citizens that we serve, the healthcare, and the innovation that is upon us in terms of enhancing future health. Well, where do we go with this. There are many directions that would potentially take us, and my suggestion would be that there are a few that we should think about. Stem cell research, reproductive technology, genomic testing and precision medicine, privacy in the electronic medical record, and the challenges and opportunities of so-called big data, the innovative personal engagement that the self-monitoring devices suggest, and importantly, as we heard yesterday and all of us recognize in Canada, is the sustainability of our public health system. This is something that is at the core, I think, of where the Academy can contribute. And as also we recognize, we're a confederation of 10 provinces with 10 different takes often on how healthcare is delivered, funded, and developed. Here is another area. We now have the disciplines, the health disciplines under one roof. Can we encourage a national strategy that brings the provinces together? I think that's a place where our leadership could well have an impact. My good friend Rob Califf, who parenthetically Mr. Obama nominated as the commissioner for the FDA a few days ago, reminds us that we're not generating the evidence that we need to support the healthcare decisions that patients and their doctors have to make every day. And so our research and our direction and where we're headed needs to overcome this unmet, this gap and this unmet need. And again, adapted from some of Rob's earlier work, my own view is that in this learning healthcare system, we need to measure, have a quantitative network development that informs public policy and educates the next generation of health professionals. And that involves not only the discovery and the preclinical science, the proof of concept studies that many of us undertake, the clinical trials that define efficacy, the guidelines that are influenced, the performance measures that are articulated in registries that we need to conduct, the population impact on outcomes, and how that then uncovers the unmet future clinical needs and feeds back into this cycle. All of us play a role in this cycle, and it's our collaboration around this that I think is part of the richness of the Academy and the opportunity. So I think we do need a Canadian Academy of Health Sciences. I think it's value-added, it's distinctive, it's multidisciplinary, and it represents the best of Canadian health science. There's the intellectual equity and the leadership for the conduct of assessments. There's an inventory of expertise that enhances our state of readiness. It informs Canadians, government, and public on key health-related issues. I think it facilitates cross-fertilization across the richness of the other academies. It allows for scanning of the international health landscape, and it is indeed a voice to represent us internationally. How do we get there? Well, we use the power of our collective ambition, as so nicely articulated here from the Harvard Business Review. We have a shared sense of purpose. We implement it, and we track our progress. We exhibit behaviors that manifest it, so we are the glue, and the grease is the assessments. And we relentlessly pursue this in the best possible way that we can. The imperatives, I think, for us are to engage our fellows and to work hard on the development of our brand at this 10-year anniversary of our genesis, to achieve fiscal stability as it relates to our independent path and our capacity to undertake assessments that we ourselves believe need to be done, as well as those that our sponsors would wish us to undertake. We need to have a national and international outreach, seek pivotal themes that inform better health for Canadians, and do assessments that are relevant to Canadians with an impact on public policy. Kathy Whiteside encouraged me to put a set of destinations for 2025. Here are a few. We would, in 2025, be the clear resource for health science advice by the public and the private sector. We'd close the knowledge translation gap between evidence and public policy. We'd be internationally recognized as a single organization aligned with a progressive healthcare system in this country, and we would be an ambassador and authoritative voice for health science internationally. Some lofty, but I think achievable goals, Mr. President. So I would say, in conclusion, that we are on the right track, but as Will Rogers reminds us, if we just sit there, we'll get run over. Thank you very much.